All right, welcome to the final part of our series on dizziness in older adults. In our first two explainers, we completely reframed dizziness as a multifactorial syndrome, and then walked through a really high-yield bedside assessment. So today, we're going to put it all together. We're focusing on building an effective, action-oriented management plan that you can start using like at your very next consultation.
Okay, let's dive right in with what is, you could argue, the single most impactful thing you can do. This quote really sets the stage for everything we're about to talk about. It's a powerful reminder that sometimes the best tool we have isn't writing a new prescription, but, thoughtfully taking one away.
So what's the big idea here? It's really about shifting our focus. We've got to move away from that often endless search for one single diagnosis. Instead, the strategy that actually works is to identify and tackle the multiple modifiable factors that are really impacting your patient's life.
And look, this isn't just some nice idea, right? It's backed by some really solid evidence, going all the way back to Tinetti's foundational work. The research shows time and time again that when we address every contributing factor in parallel, we're talking vision, medications, strength, vestibular function, the whole shebang, we get way better outcomes than if we just try to fix one thing. The real success is in treating the whole picture.
All right, so where do we even begin with all this? Well, we start with a single highest yield intervention you can make. Before you even think about referring or ordering a bunch of tests, your first move should pretty much always be a structured medication review. This is where you can make a huge, huge difference, and often really quickly.
Okay, this slide is fantastic because it breaks down the main culprits for us. For antihypertensives, what's the deal? It's orthostatic hypotension. So the approach is to ease up on those blood pressure targets and get rid of things like alpha blockers first. For benzodiazepines, it's all about that CNS depression. The key is a slow, careful taper while you bring in good sleep hygiene. Anticholinergics, they cause cognitive issues and instability, so we actually calculate the burden and swap them out for better alternatives. And last but not least, vestibular suppressants, which definitely deserve their own special warning.
Now, the good news is you don't have to reinvent the wheel to do this safely and systematically. These two tools, the Beers criteria and the stop/start tool, are your best friends here. They're the best validated checklists out there for geriatric prescribing. Honestly, making a review with one of these an annual thing for any older patient with dizziness or falls, that's a real game changer for your practice.
Okay, and this right here is an absolutely critical clinical pearl. It's such a common reflex to prescribe drugs like prochlorperazine for dizziness, but for chronic problems, this is a huge mistake. Long-term use actually hurts the patient. It suppresses the brain's natural ability to compensate, all while increasing sedation and the risk of a fall. You've got to limit them strictly to the first couple of days of an acute vestibular crisis, never ever for ongoing management.
All right, so once we've got the medication side of things sorted, what's next? We move on to the other part of our parallel plan, rehabilitation and falls prevention. Deprescribing is a massive step one, but these active therapies are what build back strength and confidence right alongside it.
Vestibular rehab is so effective, and it's not some kind of magic black box either. It's built on these three solid, evidence-based pillars. You've got gaze stabilization, which retrains that vestibulo-ocular reflex. Then there's balance and gait training, usually under tricky sensory conditions to really improve stability. And finally, habituation exercises, which help dial down the symptoms that get provoked by certain movements. And here's a really key bit of evidence that'll help make your referral super effective. While home exercises are fine, the data is pretty clear that for older adults, a supervised 12-week program gets significantly better results. Why? Well, the structure and guidance make sure they're doing it right and actually sticking with it, and that leads to much more meaningful improvements.
I love this slide because it just perfectly lays out the two parallel streams of management. You have to do these at the same time. So on one side, you're doing the specific treatment for a diagnosis if you find one, like the Epley for BPPV, but on the other side, you are simultaneously rolling out a big-picture comprehensive falls prevention plan. This is the stuff that addresses that underlying frailty and all those risk factors, covering everything from strength training like Otago or Tai Chi to getting an OT to do a home safety review.
Okay, so you've started deprescribing. You've kicked off a falls prevention plan. Fantastic. But what about the safety net? When is it actually time to escalate and get a specialist involved? Knowing these triggers is absolutely crucial for your patient's safety.
This is the big question, right? When do you actually make that call for a specialist assessment?
Yet getting this right is just so critical for managing patients safely and making sure nobody falls through the cracks. So here are your non-negotiable triggers. If a patient is having recurrent falls and there's a clear vestibular piece to the puzzle, or you suspect something deeper like presbyvestibulopathy, it's time to refer. Same goes for BPV that just won't clear up after 2 good tries at the Epley. Or if you've done your workup and you're still just scratching your head. And it goes without saying any acute change with new neurology needs an urgent look.
Okay, I know we've covered a ton of ground here. So to make this all super easy to remember and actually use in a busy clinic, let's boil it all down to 3 simple, actionable steps. So really, it all just boils down to this. Just 3 key actions. That's it. This is the core of excellent care. And here they are. Think of this as your new management mantra. Number 1, deprescribe first. Always start by tackling polypharmacy. Number 2, rehabilitate in parallel. Build that big, comprehensive rehab and falls plan at the exact same time. And number 3, refer with confidence. Use those clear triggers so you know exactly when it's time to escalate. And just like that, that brings us to the end of our 3-part journey. We started by reframing our whole understanding of dizziness. Then we walked through a practical bedside workup, and now we've landed on this actionable parallel treatment plan. I think the key message, really, is that dizziness in older adults is rarely one big thing. It's a bunch of small, treatable issues that when you tackle them together can really give someone their function and their confidence back. Hey, thank you so much for joining us for this series. To explore more resources for both clinicians and patients on dizziness, vertigo, and imbalance, please visit our website at australiandizzinessclinics.com. And hey, if you found this useful, don't forget to subscribe, and please let us know what you thought by leaving a rating. It really helps us out.